Good afternoon. It's already 2 o'clock, so we'll start. I'd like to welcome everybody. Please mute yourself, but always show your video picture. Sign in your name, Facebook account, or email address in the chat box. Please include names of companions attending. Use the chat box to ask questions and make comments while the pep talk is on. There'll be group pictures at the start and end of the pep talk. Please show your face during the picture taking. As a reminder, please take the online Learning Cum Evaluation Test exercise, or OLETE, for mastery of learning and have a perfect score to get a certificate. I have placed the link in the chat box. Okay. Also, as a reminder, obtaining 50 OLETE certificates will entitle one mentee to a voucher for a free ROJoson telemedical consultation. So let's now have a group picture taking before we start in 2 minutes. Please turn on your video and show your face. Okay, we'll see if we can have these new views. Something new, okay. Everybody's face is there. Okay. So we'll have 2 views. We'll go to the old views later on. Okay, we start with this one. 1, 2, get ready. 1, 2, 3. Okay. Mm-hmm. Okay. So let's have this view. I think this will be nicer. So we can really see the faces of everybody. Okay. Okay. Seni, okay. Lorly, can you show your face, Jeng? Lorly. Okay. 1, 2. 1, 2, 3. Okay. Okay. Let's start. I have a patient empowerment program in which I like to empower the lay people or patients to take control in the management of their health. There are 3 courses in the pep talk. I completed the core course on October 9, 2021. And from October 23, 2021 onwards, I have been tackling health disorder and health issue courses. This may take 3 years or longer depending on your enthusiasm. My pep talk today is entitled Fundamentals and Generalities in the Medical Management of Skin and Soft Tissue Tumors, Part 2. This is part of the health disorder course. The empowerment objective is for the lay people to have an understanding of the fundamentals and generalities in the medical management of skin and soft tissue tumors, Part 2. Last week, as Part 1, I took up these various topics. What is a skin tumor? What is a soft tissue tumor? What are the different types? What are the different causes, and how common are those tumors, skin and soft tissue tumors? Today we will be tackling Part 2, clinical diagnosis of skin and soft tissue tumors, paraclinical diagnostic procedures, treatment, and prognosis. Definition of terms in the title and the limitation of the coverage of my talk. One, the word fundamental to mean simplest and essential facts and theories which can serve as a basis or foundation and support for advanced information. The word generalities to mean general statements of information, not covering specifics and details. And lastly, the phrase medical management. This will be used to mean diagnosis and treatment by physicians. Let's start with the first topic, clinical diagnosis of skin and soft tissue tumors. When you say clinical diagnosis, it just means the conclusion or decision made by a physician after examining a patient and after evaluation of the data on symptoms and signs. Symptoms are those that are felt and observed by the patient or a person on his or her body, whereas signs are findings of a physician after doing a physical examination of a patient. The procedures in doing a clinical diagnosis of skin and soft tissue tumors consist of the following. It starts off with the patient presenting with symptoms, and then upon consultation, the physician evaluates the symptoms to look for cues for a skin and soft tissue tumors, and then cues or pattern for a particular or specific skin and soft tissue tumor. Then the physician does physical examination to look for sign cues of skin and soft tissue tumor, and then cues or pattern of a particular skin and soft tissue tumors. And lastly, as a last step, the physician processes the symptoms and signs to determine, number one, whether a skin and soft tissue tumor is present, and two, if present, what type, or in other words, concluding with a clinical diagnosis. Okay. And the processes used in the clinical diagnosis of skin and soft tissue tumors, as we have been mentioning this in the past so many sessions, pattern recognition and prevalence. These are the two processes. Okay. So pattern recognition process means realization that the patient's presentation conforms to a previously learned picture or pattern of a particular disease. And prevalence process means the choice of a diagnosis is based on the frequency of occurrence of the disease in a certain locality, in a certain age and sex group, and in the affected organ and system. So pattern recognition takes priority over prevalence process. Okay. The common symptoms that will lead to a suspected skin and soft tissue tumor is the presence of a tumor or mass or buccal felt and or seen on and over the skin. Okay. So symptoms, the patient will say, I have a buccal, I have a mass on my skin, on my upper, my arm. No? Okay. So right away, the physician will suspect, is there really a lump? Is there really a mass? Is there really a mass or a buccal on the skin, on the upper arm? So he will examine that patient and then decide whether the tumor is just on the skin, so it's a skin tumor. If it's on the below the skin, it's most likely a soft tissue tumor, or sometimes it could be a combination of soft tissue tumor and skin tumors. Okay. Then after that, diagnosis of skin and or soft tissue tumor, the physician determines what type of tumor is present. Okay. So just looking at the tumor, if there is really a tumor on the patient's body, okay, if the tumor is located on the skin or in the skin, then it's a skin tumor. Okay, so if the tumor is located in and on the skin, like this one, okay, this level, so right away you can say a patient has skin tumors. Okay, if it's a little deeper, okay, sometimes you cannot really determine whether it's a soft tissue or skin tumors. Now, the best way to determine is how superficial is the tumor. If it's just beneath, right beneath the skin, then it could still be part of the skin. Okay. So we consider a tumor to be soft tissue tumor. Number one, if it's below the skin, you don't see any changes in the skin. And deeper, okay. So it could be on the subcutaneous fat or in the muscle layer. Okay. So if you have a presentation like this, a tumor located at this level, okay, then you consider a soft tissue tumor. Okay. And make sure that the tumor is not bony hard. If it's bony hard, it's a bone tumor. Okay. Okay. So bone tumors, so these are the tumors located in the bone. Okay. So try to differentiate bone tumors from skin and soft tissue tumors. The best basis here is the consistency of the mass, whether it's bony hard or not. If it's bony hard, then it's bone. If it's not bony hard, it could most likely it's skin and soft tissue, and try to check the superficiality of the mass, whether it's a little superficial, not deep to the bone, then you consider it as skin and soft tissue tumors. Okay. So a skin and soft tissue tumor is an unusual and abnormal collection of tissue occupying the skin level, okay, occupying the skin. Okay, here, another example of a skin level tumor, okay. And soft tissue beneath the skin, soft tissue, okay. So skin tumor, soft tissue tumor. So just by looking, a lot of times you will know what it is already, okay. But sometimes, rarely, it could be a combination, okay. So, but if you see something like this, most likely this is a skin tumor, but you have to examine it deeper and see if there is an underlying mass beneath the skin. So it could be a combination of soft tissue tumor and skin tumors. Okay. So this one, definitely this is a soft tissue tumor, unless it is very, very superficial. Okay, then it could still be part of the skin. But here, definitely it's arising from the skin, so you label this as skin tumor. And try to remember to differentiate the skin and soft tissue tumor from prominence. Okay, here it's just a prominence. Okay, prominent jaw. Okay, enlargement. This is enlargement of the breast. It's not the soft tissue tumor. And then induration. Okay, like thickening. Okay, so thickening is not a tumor. Okay, swelling is not a tumor. Okay, and then discoloration and rashes, these are not classified under tumor. Okay, an infection of the skin and soft tissue may present as a tumor. Okay, this is quite common. Okay, usually the tumor is what is called an abscess. When you say an abscess, it is one that is belongs to the category of infectious disease, and one a mass that contains a pus, nana. No? So skin tumors can, as mentioned before, skin tumors can arise from different types of cells. Okay, and soft tissue tumors can also derive from various types of cells and tissues. Okay. So example of the types of skin tumors based on the origin. Okay, so basal cell carcinoma usually arise from basal cells, but this can only be known through the microscope examination. Squamous cell carcinoma arises from squamous cell cells, and then for the melanocytes, it can give rise to moles or nevus and melanoma. This is the counterpart of cancer counterpart of mole. And then from the skin glands, you can have seborrheic keratosis, seborrheic adenoma. Okay. From the blood vessels, you can have hemangioma, lymphangioma, and then from the nerve, neurolymphoma, connective tissues, and fibroma. Okay. So specific uh, clinical entities of skin tumors, which are quite common that has to be mentioned. These are the epidermal cysts and the warts. Okay. Now, for soft tissue tumors, the fatty layers or the fatty tissues can give rise to lipoma, or the counterpart, the cancer counterpart is liposarcoma, which is not very common. Muscular tissues can give rise to rhabdomyosarcoma. The cancer counterpart is rhabdomyosarcoma. And connective tissue can give rise to fibroma or fibrosarcoma, blood vessel tumor, hemangioma, hemangiosarcoma, nerve tumor, neurolymphoma, and neurosarcoma. Okay, so fortunately, most of these the cancers are not common. Okay, so more common are the benign ones. Okay, and the most common still your fat tumors, lipoma. Okay. But it all depends on the appearance of the tumor to make a specific diagnosis. So how to diagnose skin tumors? Let's start first with skin tumors. I'll give you some tips, okay, on how to recognize skin tumors. Okay, as a review, okay, the skin is made up of the epidermis and the dermis, quite superficial. Okay, okay, okay. If you have a tumor on the fatty layer, it's a soft tissue tumor. Okay. So the trick here is to look at and feel at the skin tumor. Okay, so you look at that skin tumor if there's a tumor there, and then you try to feel it. Okay, to try to get the some information as to what it is. Okay, then by looking and feeling, you answer these questions: whether it is confined to the surface of the skin like this, okay, or whether it is right beneath the skin, just below the skin, okay, at the level of the dermis and dermis, okay, and look at the appearance of the skin tumors. Okay, there could be some appearance of the tumor which will give the diagnosis away. Example, if there is bluish discoloration of the surface of the mass of the skin tumors, you might be dealing with a blood vessel tumor. Okay, if it's black, then most likely you might be dealing with a mole or a melanoma. If it's brown, most likely you are not dealing with a mole or melanoma. Okay, so the appearance of the skin tumors is also a helpful tip or helpful way of diagnosing skin tumor. Okay, so to facilitate how to diagnose skin tumors, the general tips that I can give you is just learn and know the pattern of the more common, just the more common. Even I myself, I don't know the pattern of all skin tumors. I just know the pattern of the more common skin tumors. Okay, and then have cues for skin abscess, because this is quite easy to recognize. Okay, so if you know that there are cues for skin abscess, you make a diagnosis of skin abscess right away. Okay, and then if there's no skin abscess, know the cues for skin cancers. Okay, which is the most important concern for the patient. Okay, so to repeat, learn and know the pattern of the more common skin tumors, cues for skin abscess, and cues for skin cancers. I will expound on this. So example, so if you see a lesion here on the skin, okay, which is a little dark brown, okay, or even black on the surface of the skin, okay, and then you can see that the border is so clean now, okay, with no change in appearance since its first detection. For so many years, it has stayed that way. So your diagnosis here is a mole or nevus. The medical term for mole is nevus, okay? Now, if you see a skin lesion like this, okay, it's a superficial skin tumor, okay, nothing deep inside, okay, it's firm, it's raised, elevated, and rough. There's a rough surface, okay, and it may appear like a cauliflower, okay. So in this case, this is an example, the picture, the pattern for a wart, okay. As I said, know the pattern for the more common skin tumors. The first one was a mole, quite common, okay, very common. And then the wart is also common, okay. There are different presentations of warts. Some will just present with a small outgrowth on the so-called early part of the wart formation. But this one is a long-standing kind of a wart, okay. So just know the different variations of warts. Okay. Epidermal cyst. Okay, this is a tumor right beneath the skin, like this one. Okay, beneath the skin. Okay, mga about 1 millimeter below the skin level. Okay, and then the clue here is that there is a punctum or an eye. We call that punctum or an eye. There's a opening in which when you press on the tumor, the skin tumor, coming out will be some whitish, grayish, dirty yellow, okay, oily substance. Okay, so if you have this pattern, this picture, then your diagnosis is epidermal cyst. Okay, this is quite common in our country. Okay, abscess. Okay. So it's a tumor immediately beneath the skin, okay? If there are pus already presenting, okay, once you see pus already, then right away, 100%, 99% is already an abscess. It's a giveaway already. But there are times in which the abscess does not present with the rupture of the pus yet. So you base your diagnosis on the presence of redness, pula, okay, tenderness, masakit, no, and then fluctuant. When you say fluctuant, when you press on it, it's depressible, meaning it contains fluid, it contains pus, okay. So at the stage in which there is no rupture of the abscess yet, you can use the cues, redness, tenderness, and fluctuant. Okay. So the most important cue there is the redness because it's quite objective. Okay. Tenderness is a little subjective because it depends on the patient's threshold. The other important cue here, objective cue, is fluctuancy of the mass. Okay. When you press on it, it's depressible, meaning it contains fluid. It's not solid. Okay. Cancer. Cues for skin cancers. Okay. So you have this tumor on the skin surface, and then if you ask the history, it has been there for months, years. Okay, does not heal. Okay, and then on the appearance, you can have raised surface on the raised borders. Okay, on the side. Okay, and then after a while, it keeps on growing. Okay, then you suspect skin cancer already. And it's not the does not have the picture of a wart, of a mole, or a abscess. Okay. But in the early stage, sometimes it's quite difficult to differentiate it from a wart. Okay, so in which case you may have to do some observation or to do some more paraclinical diagnostic procedure like biopsy. Melanoma, okay, it's a brown black tumor which has grown in size over time. Okay, so you can see that it has gone beyond the border, spreading out. Okay, sometimes you can also have a change in the color. Some are lighter than the adjacent area. So in which case you suspect already melanoma. Okay, cancer of the mole. Okay, so for soft tissue tumors, okay, so here are some of the tips. Okay, look at, look again, inspect, and then feel the soft tissue tumor. Okay, okay. So put more emphasis on the feel because the tumor is below the skin. Okay, unlike in the skin, you can easily look at the appearance of the tumor, skin tumor. But here, for soft tissue tumors, you won't see the external appearance from the skin level. So you have to feel the soft tissue tumor. Okay, and then when you feel the soft tissue tumor, try to determine these things. Okay, number one, whether solid or cystic. Okay, the way to determine whether it's solid or cystic, just press on the tumor. Okay, and if it's depressible, such as like it contains fluid, then it's called cystic. Okay, if it's not depressible, then it's called solid. Okay, if you have a cystic condition of the soft tissue tumor, usually it carries a good prognosis. Most of the time, 99% of the time, it's benign. Okay, but for solid tumors, it can be malignant, it can be benign. Okay, then, but not all solid tumors are malignant. Okay, now for the border, whether the border is clear or not. Okay, if the border is clear, most likely it's benign. Okay, if the border is not clear, okay. When you say it's not clear, I'll show you later on a picture, but I'll finish this one first. Then consistency, whether it's hard or not hard. Okay. So usually when you have a hard mass, no, it connotes, it could imply malignancy, especially if the tumor is quite deep. Okay. And then tenderness, present or not. Okay. Again, as I said, if you have tenderness, most like there's a good chance that it could be a benign lesion, and also it could be a inflammatory lesion. Okay. Then, of course, there are instances in which these soft tissue tumors have gone out to the skin. So you also look at the appearance of the tumor on the skin surface. Okay. So tips here will be to learn and know the pattern of the more common soft tissue tumors. Okay. And then know the cues for soft tissue abscess, and also know the cues for soft tissue cancers. So right away, I'm going to tell you that the cues for soft tissue tumors are the following. One, it's deep down at this level, usually muscular level, deep down in the muscular level. Okay. If it's a little superficial on the fat layer, most likely you don't have to be alarmed. Okay, but if it's deep down to the muscular layer, then you have to be alarmed. And then if the mass is also hard and also fixed, more so. Okay, so these are the cues for soft tissue cancers, which are usually called sarcomas. Okay, so earlier, I talked about the border, whether it's clear or not. Here is an illustration. Okay, so the border is very clear. Unlike in the not clear border, it's sabog, no? Okay, when you touch the border boundary, it's sabog, no? But here, you can indent your finger between the normal and the tumor. Okay, like this one, no? Okay, clear border. Okay. So if you have a soft tissue tumor at the level of the fat, subcutaneous level, and then it's solid. As I said, not all solid are cancers. Okay, if it's solid and then there's a clear border, and then it's soft because fat usually are soft. Okay, it's movable. Okay, and it's non-tender, and then there are no skin changes, then you make a diagnosis of lipoma. Okay. So this is the most common benign skin tumors, okay, in the body. Okay. So take note of the lipoma. Now, the other types of the skin tumors, there are so many, but I'll just mention one. Okay, just to drive home the point that you have to know the pattern of the more common soft tissue tumors. Okay, so the clue here is that if there is bluish discoloration, okay, so you might be dealing with a blood vessel tumor. Okay, if there's no discoloration, then if it's deep, then you may have to think of the soft tissue sarcoma, or the cancer equivalent of the soft tissue tumors, especially if it's hard and if it's fixed. Okay, so that is what is meant by looking at the appearance of the skin surface. Look also at the color of the skin. Okay, so let's now go to the second topic, paraclinical diagnostic procedure for skin and soft tissue tumor. The foremost indication for a paraclinical diagnostic procedure can be stated this way. If you are not certain on the primary clinical diagnosis and you need to be certain or be more certain before treatment, then go for a paraclinical diagnostic procedure. Example, if you look at the wart, that's just by looking and feeling the skin tumors, you know it's a wart. No, it's a mole. Another example. So you're quite certain, then you don't need to go for a paraclinical diagnostic procedure. But if you're not sure of what you saw, what you feel on the skin tumor, then you go for a paraclinical diagnostic procedure. So to decide on the indication of the paraclinical diagnostic procedure, the physician uses two processes again. Just like in the clinical diagnosis, you have two processes, which are pattern recognition and prevalence. Here, for the indications for doing paraclinical, you have two processes that we use also. One is the degree of certainty on the primary clinical diagnosis. Okay, if you're not certain, you go for a paraclinical. If you're quite certain, you don't have to go for it anymore. And then the other process that you use is that if you're not quite certain whether it's what is the real diagnosis, then you try to look at the treatment plan for the primary and secondary. Okay, if the treatment plans will be the same, even though you're not certain, let's say you have to excise it, remove it, no? Okay, then you don't need to go for a paraclinical diagnostic procedure anymore. So if there is a need for a paraclinical diagnostic procedure, the physician uses the BRCA processes. B stands for benefit, R risk, then C cost and availability. Okay. So usually physicians do not do this, do not tell you all this, give you this data. So just ask the questions, what are the benefits, what are the risks, what are the costs, and is it available, readily available or not? Okay, the diagnostic procedure. Okay. As I said, the physician should give you the list of the options, and then after that, he will advise you or he will give you the freedom to make a decision. Okay, so you're asked, what do you want? No? Do you want this one, option one? Do you want option two or option three? Okay. Of course, you'll be guided by the physician. Okay. So example of the BRCA comparative analysis of a paraclinical diagnostic procedure. Example, if option one has an accuracy of 99%, okay, the goal here is to be more definite on the diagnosis. Okay. So example, you're not sure of the clinical diagnosis of a skin tumor or soft tissue tumor. Let's say it's only about 70%. Then you decide to have a paraclinical diagnostic procedure, then you compare the three options. Okay, the option 1 has 99% accuracy, then option 2 has 90, and option 3 has 60. Just based on the benefit or the goal, of course, by by common sense, you will be choosing number 1, right? Accuracy is 99%. No? Okay. Usually we don't choose accuracy below 90%. Okay. 90% pwede pa. Okay. But below 90%, no, usually we throw it away. We don't do it. No? Okay. Then you look at the risks. So what are the risks of the procedures in terms of bleeding, infection, trauma, pain, and then also the convenience or inconvenience. Okay, suppose the risks are all acceptable. It's quite meaning it's not so common. Okay, 1%, 2%, and then you can live with the inconvenience of doing that procedure. Okay, and then the next thing is to look at the cost. Okay, suppose the cost for option 1 is 4,000, 3,000, and 1,000 for the option 3. I'll go back to this, but let's just finish this one. Suppose they are all readily available, then how do you choose? Okay, so even though this is the least expensive, no, you don't choose option 3 because the accuracy is 60%. No, okay. So don't waste your money, 1,000 on this one. No, okay. So the very least is that you choose this one. Okay, 90%. But if you still can give out 1,000 more, at 4,000, you go for this one. The accuracy is 99%, so 4,000. No? Okay. The common instrumental and laboratory diagnostic procedure that can be used for the clinical diagnosis of skin and soft tissue tumors consists of the following, but basically it's the biopsy. That's the most common. Okay. Biopsy is defined as obtaining and examining under the microscope samples of body cells and tissues, okay, which are gotten through the various techniques. Okay. So you must have a sample of the skin and soft tissue tumors, and then have them examined under the microscope. That is biopsy. Okay. So there are several types of biopsy. One is the so-called closed biopsy. When you say closed compared to the open, in contrast to the open, you see closed then open. So in the open, you have a preliminary cutting of the skin, okay, to get to the sample, Whereas in the closed biopsy, you don't have any skin cut, but you can have a needle puncture, okay, needle biopsy is, okay. So without cutting through the skin, but you can poke in a needle, okay. The needle can be fine needle, meaning a small bore needle, or a core needle, a bigger bore needle, which can get more samples, bigger sample size, no? Okay. So the other type of biopsy is punch biopsy, in which you just put in that equipment puncher, just like punching the ticket in the when you ride the bus. Okay? So the bus conductor usually punch the ticket. Okay, so punch biopsies has a similar concept there. Okay, then pinch biopsy. This is my own creation, because sometimes I see tumors like this already fungating. Okay, just by touching it, it will just be detached. No, okay, so just pinch it and then just submit that for biopsy. Okay, so I call it pinch biopsy. You don't have to use an instrument, punch biopsy, or at most you can use a small knife and just to cut off one segment of the tumor. No? So that's what is called pinch biopsy. Competencies required of physicians managing skin and soft tissue tumors. So be guided by this, okay, so that you know which doctors to trust your biopsy. So the doctor should know the uses and indications of all known instrumental and laboratory diagnostic procedures for skin and soft tissue tumors. So they should not be limited to one or two, okay, okay. because sometimes they just limited to one or two and then they stick to that without considering the other options. Okay. Then the other competency is they are required to use them only as needed and as indicated. So they should know the BRCA, no? And then they should also know how to select the most cost-effective one. Again, they have to use the BRCA for decision making. And lastly, they must know how to interpret the results. Okay, they don't just rely on the report of the pathologist when they have the biopsy. Of course, they consider the report, but they do not. They have to correlate the report, the result, with the clinical findings and see whether the result jibe with the primary diagnosis. If jibe with the primary or the secondary diagnosis, they accept. If it's not, then they make a decision whether to put it on hold or repeat the biopsy. Okay, so that's the decision making that the competent physicians will have to do. They must know how to interpret the result and make a decision what to do, so as to arrive to the pre-treatment diagnosis. Now, for skin over soft tissue tumors with intact skin, just like here, okay, so you cannot do pinch biopsy here. Okay, you can do needle biopsy. Okay, so here you have two techniques that you can be done. Close biopsy, you can do needle biopsy using a fine needle or core needle without cutting through the skin. Okay, so this is done only when you are not sure whether this is lipoma, this is a nerve tumor, okay, or a sarcoma and other diagnoses. So then you can do a close biopsy, okay? Or if you are suspecting soft tissue sarcoma, okay, and then you know that there is a limitation, that is the needle biopsy only has accuracy of 80% with soft tissue sarcoma, then the surgeon, the physician can opt for an open biopsy, okay? So to remove a part of the tumor, okay, which is called section. Or if it's small, just remove the entire tumor already, okay? Okay, if it's a big tumor like this, about 5-10 centimeter in size, no? So to do a preliminary study, they just get a section, let's say 1 cubic centimeters. This is what is called section open biopsy. Okay, if it's removal of the entire mass, then you call that excision open biopsy. So this table shows a comparison of the BRCA on a biopsy procedure for soft tissue tumors. Okay, so if you have these options, fine needle, core needle, and open biopsy, which means cutting the skin and then getting a sample. So take note, the usual data that you will get will be in terms of benefit. Benefit means to be more definite on the diagnosis. No? Fine needle has a 90% yield for most tumors, but there are instances in which the diagnostic yield of a fine needle can be less than 90. So you don't use the fine needle, okay? But suppose it's 90% yield, and then core needle, because it uses a bigger gauge needle, bigger bore, mas malaki, no? To get a bigger sample, then you can have a 95% yield, higher yield. Open biopsy, get a direct sample, 1 cubic centimeter, or even the entire tumor, then you have a 99% yield. There's no such thing as 100%. No? There's always some percentage of error, no? or limitations. No? Okay, in terms of risk, no? Okay, talking about invasiveness of the procedure, okay, least invasive is a fine needle because just small needle, just like your injection, and then core needle, bigger gauge, so mas masakit, okay, and then more complications, and then open, the most invasive, especially when there's a associated scar, okay. Then look at the cost, okay. Example, if the cost is just 1P, then 2Ps and 3Ps here, then you choose which one will be the best for you, okay? And then assuming that they're all available, usually they're all available now, okay? But Sometimes the core needle, it's a special instruments. It may not be readily available. So you may have to choose fine needle or open biopsy. Now, in terms of treatment, the third topic, I'll just give a short explanation here. For the skin and soft tissue tumors, the main modality, the usual, practically the one and only modality of treatment is operation nowadays, okay? So it can either be excision or wide excision. When you say excision, it's usually, suppose this is the tumor, there's the margin there, so you just excise the tumor close to the, just a little margin, now just to make sure it won't, that you have removed it totally, it won't recur, because if you cut through this one, you leave behind the tumor, and then it might recur. Okay, so you give a little margin now, so that to ensure that there is complete removal of the tumor. Okay, wide excision is illustrated by this outer, okay, arrow, circle. Okay, there is a good margin here. Let's say 1 centimeter, 2 centimeters margin, or sometimes for some tumors you might need 3 centimeters margin. Okay, this is what is called by wide excision. Okay, and wide excision usually is used for cancer tumors. Okay, but for excision it's used for non-cancer tumors or for benign tumors. Okay. Other treatment modalities can be added, especially for cancer tumors, such as radiation and or chemotherapy, okay, especially those with sarcomas, okay, sarcomas, soft tissue sarcomas. For melanomas, yes, sometimes you can use radiation and also chemotherapy for melanomas, okay. Prognosis, fortunately, generally good, especially if diagnosed and treated early. Okay. For non-cancer tumors, whether skin or soft tissue tumors, majority will be cured. Example, you have lipoma, you have a wart, you just remove it, okay, majority will be cured. Okay. But for the cancer tumors, majority will be cured also if treated and diagnosed early. Okay, if it's still small one, and then, but if it's diagnosed late and treated late, then the prognosis will be poor. Okay, there will be a high chance of recurrence. Okay, and notably, those with poor prognosis are, as mentioned earlier, sarcomas, soft tissue sarcomas are usually carry a poorer prognosis, and also melanomas. Okay, so try to catch these two types of cancers in its early stage and have it treated right away. Summary and takeaway for this part 2, I have tackled these topics: clinical diagnosis of skin and soft tissue tumors, paraclinical diagnostic procedures, treatment, and prognosis. Okay. Takeaway in relation to patient empowerment: be always in touch with reliable medical information on the fundamentals and generalities in the medical management of skin and soft tissue tumors. Knowledge is power. It gives power. Use the 4 Ks of patient empowerment, which are kaalaman, kakayanan, karapatan, and kapangyarihan, to gain greater control over decisions in the medical management of skin and soft tissue tumors. So with that, I end my pep talk, Fundamentals and Generalities in Medical Management of Skin and Soft Tissue Tumors, Part 2. I hope I have empowered you to have better understanding, more understanding of the fundamentals and generalities of the medical management of skin and soft tissue tumors. Thank you. Okay. And then before we go to the question and answer portion, as a reminder, please take the Olete. I hope you have seen the link in the chat box. Okay. And then try to get 50 Olete certificates. We're now on the 39th or 40th Olete pep talk. Okay. So 10 more or 11 more, then you will have a voucher for a free ROJoson telemedical consultation. So with that, let's have a picture taking, group picture taking. Okay. One. Frances, you want to show your face, Frances? Okay. 1, 2, 3. I'll see again. Wait, I will check. I'm experimenting with this one. Mas maganda ba ito? Okay,
Parang
okay.
nasa klase tayo.
Let's take a shot.
Parang tayo nasa auditorium.
Okay, yan.
Like ko konti, no? Is this better? Let's have another shot for this one. 1, 2. Where am I? Okay.
Right side, Doc.
Okay. You cannot move it, no? 1, 2, 3. 1, 2, 3. Okay. I'm trying to experiment all these good pictures. Okay, the floor is now open for questions, interactions, comments, suggestions. Any questions? You want this view or the other one? Back to the old view. Anybody who will give me a suggestion? I bet which one do you want? This one, this view?
Yeah, I like this for a change.
Maganda.
I cannot hear you.
For a change, yeah, it's better.
Okay, I cannot hear you. Are you talking, Abet? Okay,
Yeah.
I cannot hear you.
Yeah. Everybody, can you hear me?
Yes.
Hello.
Yes po.
Yes.
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 Can you say something, Abet? So, how come I cannot hear you?
Can you hear me?
Yes.
Yes.
Okay, okay.
Yes.
Okay. I had my speaker off at the okay.
Okay.
I can hear you. But you were able to hear me in my lecture, no? You were able to.
Yes, yes. Clear.
Okay. So any questions?
Right.
Andali. May nag-echo. Is it mine? Nag-echo. Okay. Okay na?
Yes, yes, Doc.
Okay.
there is a question from Jocelyn T. Is it possible to have a dermatologist remove facial warts after an operation of another part of the body while the patient is still asleep after the operation in the operating room?
Okay, so the question here is assume this. Okay, so the patient is undergoing another operation. Okay, one operation,
Yes, Doc.
and then let's say gallbladder surgery. Okay, undergoing gallbladder surgery, and then while he is asleep, or
Mhm,
whether he's asleep or not, no,
mhm.
can a dermatologist come in and remove the wart? Yeah, strictly speaking, yes. Okay. Hello? Hello?
Yes, yes, yes.
Gallery view. Okay. Strictly speaking, pwede, no? But
Mhm.
in practice, usually unless talagang the wart removal will entail anesthesia, ano? A big amount of anesthesia. Let's say marami, ano ito, is facial warts, di ba? Marami.
Yes, yes.
So you can request the derma, but he has to bring in his equipment, no, into the
Mhm.
operating room. He has to bring in his equipment to the operating room. If the sometimes the hospital does not allow the derma to bring in the equipment kasi they cannot charge,
Oh.
di ba? So the derma can charge with his equipment, but the hospital cannot charge, so they may not allow it
Oh.
sometimes, no? So yeah,
Mhm.
so it all depends on the policies of the hospital, no?
Mhm.
So talk it over with your derma and also your surgeon who will operate on your gallbladder. Okay. Theoretically, it's possible.
Thank you, Doc.
Because what you want is to avoid the anesthesia.
Yes, and the pain.
Yeah.
Parang double pain.
Okay. Para ano na. Okay.
Thank you.
I see your point. Yeah. Okay.
Yeah, yeah.
Any
But
more?
it's COVID time, I think impossible, no?
For the wart?
Yes, yung double na gagawin after the surgery, wart removal.
Pwede naman, as long kasi kung let's say I don't know whether the hospital still requires RT-PCR for operations, no? Okay.
Mm.
Okay, there might be still I don't know when they will lift that, no? Okay, but at the moment, I think all patients who will undergo operations will have RT-PCR, make sure that it's negative 3 days before, no?
Yes.
Okay,
Yes.
then she will be admitted for the operation, no?
Yes.
Okay, so in that case, para isa na lang, I don't know the derma whether she will need RT-PCR in his clinic, di ba?
Oo nga naman.
Okay, so you inquire na lang. I don't know. Maggulo ngayon magulo yung policy.
Yes, yes, yes.
So I really want to I really hope that everything will die down and then we go back to the normal without RT-PCR anymore testing. No?
Yes, yes. Thank you, Doc.
Okay. Any more?
Doctor, in follow-up to the question of Mrs. Jocelyn T, can the surgeon also do the cauterization instead of the dermatologist?
Yeah, the surgeon can do it as well.
Yeah, diba?
Very nice question, Beth.
If you're thinking about the cost, the expenses, why get another dermatologist wherein the surgeon can do it also?
May I ask Doc Joson if he has ever done that?
Yeah, 1 or 2 lang, 'di ba? May wart siya. Kung minsan, nakita ko may wart, may skin tag. I remove it, no? Okay.
Oh, is the machine readily available for use in the operating room?
Kasi yung when you talk about facial warts, no, if it's marami, no, Okay, they usually use the small tip, di ba? Yung cautery tip na maliliit na. Okay. And usually the derma has a special equipment for that, di ba? Okay. Okay. So if the equipment is readily available in the operating room, okay, and as long as the surgeon is willing to do it, she can do it, no? And then when I say willing to do it, basta hindi niya masasagasaan yung derma. Baka you have your dermatologist already, di ba? Okay, you're consulting a derma, baka magalit yung derma mo, derma to the surgeon, no? Okay. So
If walang derma,
yeah, talking from personal experience, you're asking my personal experience. I have removed one or two warts now in the, let's say, in the neck. Now, when let's say I'm doing a thyroidectomy, okay, thyroid, na on the neck na rin, tulog siya, di ba? Na nakita mo, may isang wart doon na eventually, baka kailangan tanggalin, sasabayin ko na. Okay, sabay na lang, na? Okay, just get the consent. Sometimes I even offered, no, even with the patient does not mind that she has a wart there, he doesn't care, no, but I said, tanggalin na rin natin para ano.
good doc.
Okay.
But how about the scars?
The scars depende nga, depende how big is the wart. Kung maliliit lang, that's why they use the yung needle point na cauterization cauterization, maliliit lang, tick, 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 gano'n. Okay. So, halos walang scar naman.
But only the derma has it, right?
Usually, kasi sa operating room, kasi ganun yan, it's hospitals just like any business. If they're not earning from it, why do they put the equipment there, di ba? Okay. So usually the operating room, they don't have those equipment because they know the derma has the equipment. They're used. Okay.
Thank you.
Okay. But if you go to aesthetic, pero hindi, if you go to aesthetic center now, in which they do plastic, no, it's quite expensive, but they have the equipment, no. Pero hindi pwede na yung sabay na gallbladder surgery and
Takot sa pain eh, doc.
yeah, okay. If it's only one or two, pwede na. So, the surgeon can do it now in the operating room. They just they can improvise. They have a cautery machine. They just change the needle, yung point, no, to a something very fine, and then tick and z. Okay.
Okay, thank you.
You're welcome. Any more questions? Yeah. So you know how to recognize skin cancer na. Huh?
Yes.
Okay, number one, you know how to recognize melanoma.
Yes.
Melanoma, ha? Okay. Yung melanoma, yung mole, observe niyo closely, ha? The moment there are changes, no, patanggal na ninyo, no? I mean, consult a physician right away, no? Okay. And then, if there's a need to remove it right away. Kasi the best outcome that you can have in the management of melanoma is early, maaga, matanggal. No? The moment it has nag-spread na sa lymph nodes or other areas of the body, usually goodbye na yon. No? Okay, hopeless na yon. No? Okay. Now, the other type of skin cancers, which are not quite common, no, but which are due to yung mga sun exposure to sun, okay, yung mga nagbe-beach, yung mga ganon, di ba? Okay. So usually nasa scalp, kumisan nasa kamay, no? And then you can see basta ugly, ang clue na lang ng ugly looking lesion. Pag pangit na pangit, patingin naman na. Kasi it's so difficult to describe in medical terms the itsura. Yung mga raised border, ulceration. O basta the clue there is something that does not heal. 1 month, 2 months, 3 months, ayaw mag-heal. No? Tapos pangit ang itsura na watak-watak, warat. No? Okay. Patingnan na ninyo kagad. No? Okay. But usually it has a better prognosis than melanoma. No? Bihira mag-spread yon. No? Yan lang, lalaki yon. No? Okay. Pero mabagal sila, na? Okay. Now, a special type of skin cancer, squamous cell carcinoma, yung mga may burns, may peklat na sa burns, no? Kung matagal yung burns, kuminsan they can give rise to squamous cell carcinoma, no? Okay. Pero bihirang-bihira rin 'yon, no? That's why it's chronic irritations that can cause the cancer, no? Okay. Now, for the others, yung mga benign, you know how to recognize a mole, you know how to recognize a wart, no? You know how to recognize epidermal cyst. Sige. I hope I have yung wart saka mole, kahit na wala itong lecture, you know na, di ba? I suppose you know. Okay, it's very common, no? But yung epidermal cyst, I hope you have learned something new today, no? Yung epidermal cyst. Basta just below the skin, tapos may mata. May mata, ha? Okay? Yan ang clue doon. May mata, may itim na ano tawag doon? Maitim na butas, no? No? Okay? So epidermal cyst 'yon. Okay? Okay. So usually pwedeng pigain para lumabas, para lumiit, no? Or kung malaki-malaki na, tatanggalin na, no? Okay? Okay. And then for the skin and soft tissue tumors, basta anything below the skin now is considered them as soft tissue tumor. Okay? Fortunately, lipoma is still the most common. No? Okay? So, kapain lang ninyo, tingnan nyo how deep is the tumor. Kung malalim na malalim, consult right away. No? Okay? Kung mababaw at usually malambot, no? At well-defined ang border, most likely lipoma lang yon, no? Okay. As I told you before, I have lipoma on my arms, di ba? Yan, no? Okay. So, bihira, lumaki yun, no? Okay, bihira, no? Okay. So, it has been here for about 30 years already, no? Okay. So, hindi ko pinapatanggal since andyan na, okay? Okay. Okay, so know when to consult, when know to have them removed right away. So that's the essence of this pep talk. No? Okay?
Doc, yung nasa arm nyo, na needle aspirate ba?
No. Just by, it started with this one. Nakita mo? Started with this one. I just feel it. Try to feel it. It's below the skin. It's soft, well-defined. It's about 1 centimeter lang. No? So my diagnosis is lipoma. So when I noticed that for the first time, 20 years ago, lipoma, then I just observed, doesn't grow bigger, no? And then lumabas itong isa. I thought it's due to blood transfusion kasi nag-donate ako ng blood. Ang sakit na nung tinusok ako rito, ala ko hematoma. So pinabayaan ko na lang kasi hematoma will resolve, di ba? Okay, pero hindi siya nag-resolve. So it has been...
May maga, parang maga.
Maga, ayan, no? It has been here for 20 years then. And then it's only before the pandemic, I decided to pina-ultrasound ko na lang. Sabi ko, I want to to settle this once and for all. Ano ba talaga? So lipoma, taba, lipoma, no? So yun.
Yun ang result sa ultrasound?
Yeah, the ultrasound sometimes can tell you how deep the depth of the buccal, the tumor, and also the configuration. No? Configuration. Usually, ultrasound will tell you the exact level of the tumor, di ba? The skin tumors, di ba? Yung skin and soft tissue tumors, I have a drawing for you now at what level is the tumors. No? So, kasi a lot of doctors don't use that way of analysis. They just say, oh, may bukol ka. Sige, baka cancer yan. Opera na kita. No? Okay. So, but with the information that I gave you, you have to determine whether it's skin and soft tissue and how deep is the tumors. No? That will give you some clue. No? Okay. Okay.
Thank you.
Doctor, what about this?
Saan?
What about this? Is this carpal? I don't know how to show the.
May bukol?
It's here.
May bukol?
Yeah. Here. I don't know if this is bukol.
Ano, is it bony?
No, it's superficial.
Superficial?
This one, can you see? This one.
Yeah. Below the, nasa base of the thumb yan, di ba? Okay. Is it movable?
No. This
Hindi,
one.
hindi siya gumagalaw?
No. Parang it's soft,
Hindi,
pero parang above the bone. No.
hindi gumagalaw?
Hindi. Ayan. Can you see that?
Bakit hindi gumagalaw? And then, okay. And then, ganun-ganun mo. Kung nag-change ang position. Okay. Okay, malambot?
Ayan, malambot siya.
Pindutin mo nga. Pindutin mo. Pindutin mo and see if there's flutterency.
Ano siya? Para siyang balloon when you press it.
Yeah,
it
good.
goes down.
Yan ang yan yung tawag na balloon or depressible. Yan sinasabi
Yeah.
niyo, ha? Okay? At least may natuto kayo sa akin, ha? Balloon, depressible, it's cystic, ha? Cystic
Ayan.
tawag doon, ha? Okay, if you have that one there,
Mawawala.
ganglion cyst ang tawag dyan.
Cystic fluid inside.
Yeah,
Yeah.
there's a grease, di ba yung joint? May joint,
Yeah.
may mga grasa dyan, mga
Mhm.
I call it grasa, di ba? Okay. So, nagpumutok lang yan, nag-outpouts, no? Kaya nagkaroon ng bukol, no? Okay. So, yan ang tinatawag na ganglion cyst. So, I don't know, okay, you can classify it under soft tissue tumor, pwede rin, pero because it's underneath the skin, no? But strictly speaking, it belongs to it's the mga bony parts na, di ba?
Mhm.
Joint, no? So, but at the moment, the diagnosis here is ganglion cyst.
Okay.
Ganglion cyst. Now, gano'ng katagal na yan?
2 months ago.
Okay, baka mawala pa yan. Okay, huwag mong i-press mo lang and then don't do it, huwag mong ipupuwersa. Kung minsan nawawala. Okay? So, pwedeng i-aspirate. No? Okay. When you aspirate, you get grease. No? That lump will decrease in size. No? Okay. So, do not be swayed by the mga ibang surgeons o operahan yan, ha? Okay? Operahan yan, no? Kumisan nalagay pa nila ng steroids, no? To make it smaller. Okay. So let it be na lang, mawawala yan, ha? Okay. So okay, that's a good illustration at least dito sa pep talk.
Mawawala po yan, Dok. Mawawala po. Nagkaroon ako ng ganyan dati.
Okay, good.
Kusang wala.
Ayan, meron kang moral supporter.
Bias yan.
Okay, anong tanong ni Chris? Ito
Ang tanong po ni Chris N ay, Doc, paano po pag nunal na nasa gilid ng mata? Maliit lang siya nung bata pa pero unti-unti lumalaki po.
Patingin nga.
Chris,
Di ba sabi ko, you have to see, you have to feel. Di ba? To diagnose. If you just tell me, mahirap But if I can see it,
So that is ganglion cyst.
wala, makatulog si Chris. Okay. Sa hobby niya, okay. So if it's as I said, if it's getting bigger, no, you consult already, no? Okay. So only I think by looking lang sa malalaman no?
Hello, Doc.
Oh,
Sorry, ako. Ito po, yung niya.
Nasaan yung hobby mo?
Try ko pakita, Doc.
Andiyan yung hobby
Kasama
mo?
ko siya. Opo. Yan, no?
Sandali
Zoom.
speaker view ko muna kasi maliit. Magsalita ka para lumabas sa speaker view.
Hello?
Nasaan? Wala sa speaker.
Hello?
Hindi ka lumalabas sa view.
Hello?
Yan, yan.
Kaya,
Saan? Turo mo.
ito.
Saan?
So, may pinakagilid ng mata niya po.
Ay, sa
Pinka
loob.
upward.
Sa loob. Okay. Ah, sa loob. Sa loob. Subconjunctival. Okay. So, bata ka pa, andyan na.
Yes,
Yes,
so,
Doc.
bata pa siya, nandyan na. Tapos parang napansin lang niya na lumalaki to habang nagkakaedad.
Okay. O sige, ganun na lang ha, kasi that's a sensitive area, no? Or baka mall pa rin yan, mall ang classification yan, no? Okay. So, but it's getting bigger, I would suggest, i-consult mo na lang sa OFTA. Okay? OFTA, no? Okay. You still have the option to observe, no? Or kung yung operation will be not debilitating kasi kasi may mga yung luha, no? There's may duct doon, di ba? Baka tamaan, no? Baka sagasaan, no? So you ask a OFTA to make a decision for you, no? Okay? To help you decide, no? Pero sa ngayon,
Pag ganon, tinatanggal ba yun? Kasi siya ayaw niyang ipagalaw eh. Ganyan.
hindi, kung talagang may suspetsya na malaking chance na melanoma, kasi yung kalaban mo lang naman nun is melanoma, di ba? So, it's better to remove it if there's a high risk of melanoma kaysa mamatay ka sa melanoma, di ba?
Okay.
Okay.
Thank you.
Pa-consult mo na lang. Okay. So, okay.
Thank you.
Okay. So, if there are no more questions, okay. Before we call it a day, okay. So, anong topic ang gusto ninyo? I was thinking, would you like to talk about abdomen?
Definitely.
Yes.
Okay.
Yes.
Kasi we started with, di ba? Breast, thyroid, skin and soft
Skin.
tissue. I'm thinking para ma-cover natin yung yung problems sa isang tao at sa tiyan.
Yeah.
Yan.
Pero maraming coverage yan, maraming segment yan, ha? Okay. Kasi you can have appendicitis, stomach cancer, pancreatic cancer, marami yan.
Gallstone.
Motor claim.
Gallbladder, no? Okay lang sa inyo?
Yes.
Yep.
Yes, Doc.
Yes, po.
Okay.
Yes, Doc.
O sige. So I will prepare a mga five sessions, baka 5 sessions on that, on abdomen, no? Anyway, so make sure that okay. Yeah. So interesado pa ba kayo lahat?
Yes.
Yes, Doc.
Yes.
Yes.
Sige. Abdomen. O sige. Abdomen for the next 5, at least 5 kasi malaking
5 session.
Malaking yan di ba?
Malaking part.
Oo, colon, kung minsan, how to deal with acute appendicitis, di ba?
Oh, yes.
Tramo to C510.
Oh, sige. Okay. So,
Thank you, Doc.
let's call it a day.
Thank you, Doc.
Thank you, Doc.
Thank you, Doc.
Bye-bye.
Thank you, Doc.
Thank
Thank
you.
you.
Bye. Have a nice day.